Jignesh, you are there? I see your name here.
Sir, what is the implant of choice in combination of fracture neck femur and shaft femur?
Sorry, can you repeat?
What is your implant of choice in distal 1/3 fracture femur, same side neck femur?
Two different implants. My choice is two different implants.
Yes, you want a distal femur nail and DHS with the
That's right.
rotation screw.
That's right. Jignesh, are you ready?
Yes, sir, I am there. Thank you very much, sir.
Your image is reversed.
Yeah, my image is reversed. I don't know why it is.
Right now. Can you start now? Here I introduce you Dr. Jignesh from Surat. He will talk on the proximal tibia. Jignesh, all yours.
Thank you very much, sir.
Jignesh,
yeah.
to see you, सबको PC and laptop उल्टा करना पड़ेगा.
I am sorry for that.
Why it has happened this way, I don't know.
I don't know, sir, why it is like that.
तुम उल्टा ही है ना ऐसा भी तो.
You can say anything, sir. Accepted.
I hope the slides are not like that.
No, slide will be correct. Should I join my screen?
Yes, please.
Okay.
Please share and join.
Yeah, sir. I'll be talking on a CT and X-ray understanding of the tibial condylar fractures. So this is very important to understand how CT and X-ray interpret the things, and we can plan our approaches accordingly.
To those of you who are not aware, I think this is the best lecture on proximal tibia you will hear.
Okay. Anytime one can stop me and ask anything, and whether that if you think the time is getting over, you can just tell me. Okay.
Time is not the issue. Time is not the issue, Jignesh.
Time is not the issue. Okay, then fine. It will be a great thing. The proximal tibial fractures, we have to understand the fracture pattern with X-ray and CT scan correlation to understand the fracture geometry very well, to plan approach and fixation methods and implants. So there are three major developments in field of orthopedics. One is technology, which has found out new implants and new instruments, so we can fix up any fracture with a mini fragment screws and plates and locking plates and all these things. Second thing is anesthesia, which has brought a changes in a way that we can operate even with 20% ejection fraction patient can be operated. And everything can be operated in regional blocks in orthopedics. So we can do a lot of things which will not be possible before 30-40 years. And another one is, the biggest thing is imaging study, which has changed understanding of all the fractures. And now we look all periarticular and intra-articular fractures differently than where we were looking before 25 years. So we have got a lot of information about the fracture pattern, and we could understand and study how the fracture pattern occurs and how we can reverse the pattern to get a proper reduction and fixation. So that is the biggest contribution in orthopedics, is imaging study. Now you see, this is AP view. but lateral view is telling something different. So we have to always see two views in a different right angle direction. Another one, this lion is carrying the cub. The man, he is amputating the neck or head, and he is telling something wrong. No, lion is just carrying the cub, not eating it, and he is telling something different than what we understand. So these are the importance of different views, AP and lateral views in orthopedics. Always take two views, two joints like that. Now, Surgeries classification. This is AP plane classification. There is no picture of lateral view, coronal plane. So in whole type 2, type 1 to type 6, all are pictures in AP view. There is no view in the lateral. Lateral view is not there. So it has not described any coronal plane fracture. It is only AP plane fracture. So what has changed everything in tibial condyle is coronal plane fractures. And when we understood it, it has changed the whole scenario and new approaches are discovered. And we are operating like now 30-40% cases, everybody is operating posteriorly one approach, posterolateral, posteromedial, and then go anteriorly and then do the things. So that is what we have understood by CT scan and coronal plane fractures. So understanding tibial condyle fracture beyond surgical classification, that we have to understand coronal plane fractures. So if I say press any key to start, so we have to find now where is the any key. So we have to just start with any key, something like that. So that is one joke. Okay, understand the fracture classification. Now, AO classification. Again, it is same. AP plane classification, CT not included, coronal plane not included, and it has included type A1 is extra-articular fractures. It is not tibial condylar fractures. Tibial condylar fractures is B and C. So whenever we read any classification, we should look at the classification like this, that what it has included and what it has excluded. So we can rate the classification's value accordingly. Now, Leo Confinance 2013 has divided this tibial condyle into three parts: medial condyle, lateral condyle, and he has given one posterior condyle, which has two parts, posteromedial and posterolateral, which are the region which were ignored in previous classifications and previous fracture types. So what happens? We could not understand this part. That's why we could not get the proper reduction and fixation of the tibial condylar fractures by conventional approaches. Because conventional approach cannot reach there. Low anteromedial or anterior median approach or an anterolateral approach can reach posterolaterally or posteromedially. Not possible. You can do something indirect, but you will not be able to reduce it properly, satisfactorily at your level. Now, this is the AP X-ray. I will put it like a normal X-ray. I will say it is normal X-ray. There is something in the lateral view. There is a spike. Now you see the CT scan. CT scan will tell you whole story. There is a ACL level, then there is a medial condyle complete fracture, there is a posteromedial apex. Everything is there. There is a commission in the PCL area, but PCL fragment is with the posteromedial condyle. Now, so it is a coronal plane posteromedial condyle fracture. So suspicion is the best diagnostic tool. If you see anything in APL lateral view which is not normal looking, even if you want to treat that injury conservatively, we should get CT scan done to confirm that there is nothing which you are missing. So CT scan is of utmost importance in any articular periarticular fracture. Now another one. See, same AP view, hardly you can give just think something is there, but lateral view is telling some spike. If you see long spike like this, it is always a medial condyle. Lateral condyle cannot have such type of posterior condyle spike. It doesn't create such spike because the fibula is overhanging, so it is preventing that spike to come out. So that fibula is buttressing it, but medially it will not. So it will definitely come out as a apex or some spike.
Dr. Jignesh,
Yes, sir.
that part of it which you mentioned just now,
Yeah.
spike is always medial and not.
Yeah, it is medial. Like it is always medial, sir, not lateral.
Why?
Because laterally there is a fibula which is buttressing it. So lateral spike doesn't come out like that. And it will not be that low also. But medial side is always like little bit low and it is angular like this in apex. Triangular.
That's interesting. Yeah.
It is always like that. So you observe all exercise, it will always like that. Because medial condyle is overhanging the shaft of the tibia. It is not in line with the canal. So that's why it develops the shear fractures. And lateral condyle is lying with the axis. So femur condyle causes a compression fracture. So you hardly get a shear fracture on lateral side, but always you get a shear fracture on medial side. So these are the, because of anatomical location and peculiarities. And laterally, the medial quadral ligament is attached to medial condyle, but lateral quadral ligament is attached to fibula, not a lateral condyle. So there again, there is a difference. So the forces are different and displacement is also different. So this, now this is the injury in CT scan, ACL level, then large medial condyle, complete total medial condyle. See, and there is the posterior medial apex. Now this cannot be fixed and reduced by any anteromedial medial plate. You have to go and put a plate something posterior. And there is, you can notice, there is some mild impaction on the posterior condyle also. Another one observation, when you see there is a large medial condyle like this with ACL level then and posterior medial apex, there has to be some posterior condyle impaction, which may need address, which may not need address. But both coronal plane is little bit uncommon than this variety. This is more common variety. The total medial condyle with posterior medial apex, with ACL, with posterior condyle depression is most common combination. Second combination is both coronal plane fracture. That occurs on a flexion injury. When the knee is in a flexion and the patient has got two-wheeler accident, basically activa injury. This is the pattern of injury. Classic. All the patients I have interrogated, they have got activa driving. Two-wheeler में activa चलता है तभी ये fracture होता है. Because it has no guards, so it causes fracture like this only. Every time I ask the patient which vehicle you are driving, and he will answer activa.
Jignesh bhai,
Yes,
good
sir.
evening.
Good evening, sir.
You said that this posterolateral component may require surgery, may not require surgery. So how
Yes.
do you decide which one you will operate and which one you will ignore?
Sir, if
How
the-
much percentage wise?
Sir, if depression is about 4-5 millimeter, you can accept it. If it is more than 5 millimeter, you can reduce by the same approach which you are taking posteromedially. You can have direct access to the fragment, and you can just do tenotomy of the middle head of gastrocnemius and put your spike just far laterally, and you can see the depression in front of your eyes. You can elevate it and put a screw or a small plate under it as a buttress, and you can fill up the coronals also if more depression is there.
Jignesh,
It is basically
I have used that approach.
Yes, sir.
My dilemma is that when the depression is mainly central part of the lateral condyle, and that brick fragment is anterior to the fibula, which I can access by suprafibular approach.
Yes,
And
then you do second approach.
Listen. Posteromedial, I'm in any case going to buttress with a plate by posteromedial approach.
Right, sir.
But there is a breach in the posterior lateral cortex. That
Right,
articular fragment is hardly 3, 4, 5 millimeters, but the
Right.
metaphyseal part is fractured. So do you address that posterolateral or you ignore because the articular part is very small?
No,
Sir,
Asim,
articular part is very small. I will ignore it.
Okay.
Jignesh,
Yes, sir.
what Asim is describing is a different injury.
Different injury. Yes, sir. I
Totally
understand.
different. What Jignesh is describing is what happens with the medial condyle. He's still on the medial condyle.
Okay.
I'm still on
Not
medial
on the
condyle.
lateral condyle.
Sometimes associated posterior condyle is there, so you have to decide that whether you will do it or not do it, something like that.
So what
But
he
this is basically
describing,
pattern describing is a medial condyle.
the medial condyle usually have an extension beyond the spine,
Yes.
wherein
Yes,
a
sir.
central depression of the lateral condyle. This is not
Right.
the same area what you have in a lateral condyle. Depression of a lateral condyle like Schatzger classification. This is
Yes, sir.
much more medial. That is what he is describing.
Yes, this is usually a medial half of the lateral condyle,
Yeah.
just by the side of PCL. So you can easily access it. Sir, so we have to always become suspicious when you see such type of injury and read 2D and 3D CT perfectly well.
So which is the most important decision making factor, like coronal axial view for deciding
Both.
posteromedial and posterolateral approach?
Axial.
Always we should read both 2D and 3D CT, axial, coronal, both. You see every cut properly. They will give you some information. And so don't see only 3D CT and just go out. It will be sometimes misleading. So if you see 3D CT, you will be able to know how much depression is there in a AP plane. And in coronal plane, you can see how much fragment is there, everything you can see. So you should always read 2D CT also.
But Jignesh bhai, do you agree?
Yeah.
Now, these two images are most important. The
Yes.
one 3D CT, which is on your slide,
Left side.
left hand side, and in the
Yes.
center, bottom.
Yes.
The axial and the 3D showing the
Yes.
spike.
Spike. Yes, sir. Sir, what I have done, I have taken the most appropriate images to show it because there is always a scarcity of the space to put it. So just to explain the thing, everything perfectly well, I put this exactly the same images where it is required. So I just got 3-4 selected images to put it here. But when we are going to plan surgery, we should see each and every image and then plan. And if possible, what you do, you can take a bone model, draw a whole thing on your bone model with the marker. And then you can decide your plate position and everything. That's best way to do it, actually. That will give you perfect idea that there is a fracture here, you are here, your fracture line is medial to MCL, posterior to MCL, anterior to MCL, wherever, then you can plan your plate position also. And you can know everything. That's the best way to learn, I mean. So here we ignored posterolateral part. We did not fix on the ACL also. It was small pieces of the ACL fragment, and we just did only posterolateral plating, and we have good function outcome. Perfect. So this was the this is how we plan out. So we see ACL fragment size, posteromedial medial condyle size. Where is the apex? Usually we try to put a plate on the apex, so it doesn't get displaced. If you put the plate somewhere else, then this is a shear fracture, it will slide. So plate is like an anti-glide plate. You put first distal screw at the apex, just distal to apex up within 2 to 4 millimeters of the bone. That will buttress and push the fragment perfectly well. Then you can confirm your reduction and then put the rest of the screws. That's the way we do it.
Jignesh bhai, one more question.
Please,
On
sir.
the medial condyle.
Yes, sir, please.
Often you use this distal radius plate.
Yes, sir.
People like me find that plate little weaker. So if the medial condyle, posteromedial condyle is fairly a big piece,
Yeah.
Do you think that Indian distal radius plate is strong enough to not to buckle?
Sir, here locally
I'm sure
made,
you are using, this is a synthesis one, or it's a...
Sir, this is locally made plate, which is
This
little
is
bit
local.
sturdy and thicker.
So how do you decide how thick a plate you want? How big a plate you want?
Sir,
Strong.
it's the feel, basically. you should not be able to, mold with the hand. Then it is a little bit thicker plate, sturdy plate. And if you can easily bend with the hand, then it is weaker plate. So this is a T plate, which is a little bit stronger, locally made. This was long back. Now I use only posteromedial anatomical plate.
Yeah,
But these are
they are
very
fairly
early. These
stronger
are
than this plate.
2013, 14, probably.
Yeah.
Asim, I agree with you.
I change over for large medial condyle from this plate to posteromedial plate.
Yeah, I use those plates ready-made.
Yeah.
So
Standard
Definitely you were
anatomical
saying
plate, locking
something.
plate now. Now I have changed over to this.
So we all agree that if you have to use a standalone plate, it has to be a thickest plate.
Thicker,
Anatomical
plate.
strong plate.
If
But
it is a dual, then probably you can get away with this plate. But
Right,
the
sir.
problem is when you put a buttress screw, the first cortical screw, the plate bends.
Plate
A
bends.
little
Yeah.
bit. The plate should have that much malleability that it accommodates that force and press and works as an anti-glide plate, one thing. And second thing, I would say don't use that anteromedial 3.5 mm plate on a posterior surface. I have seen a lot of X-rays like that, but it's not the plate to be used here, which is anteromedial plate, actually designed for anteromedial condyle. T buttress plate, locking. It should not be used on a posteromedial surface. We have already got a dedicated posteromedial locking plate available, anatomical, which is better and fits much better. We'll have further access, so we'll see that plate. Okay. Now, these are the two comparing view, AP and lateral, of two different knee with lateral condyle fracture. Okay. So we got the CT scan done. So it is a lateral condyle depressed fracture. On left side, it is anterior. And right side, it is posterior. So this side is lateral condyle, which is anterolateral condyle. Here it is a posterolateral condyle. You can see 3D CT with 2D CT cut anterolateral and here posterolateral. So this is the importance of 2D and 3D CT. one can easily identify the fracture where it is, which cortex is intact, and what is the approach. So, see, both are same looking X-rays, but one lateral condyle is anterolateral condyle, one lateral condyle is posterolateral condyle. And in both the cases, you have to change the approach. So one can be easily addressed by anterolateral standard approach and raplet. Second case can be done by very nicely by posterolateral approach, direct reduction and just T-plate and screws. So this is what is the importance of CT scan. So I always say CT scan is must.
So even on this, there is line in the coronal.
Yes, sir.
So in axial CT on the left bottom part, isn't the posterolateral fragment also separated from the posteromedial part?
You can say in 3D CT also, there is one line going completely fracturing the lateral condyle. But it is not displaced, but the whole thing is basically anterolateral depression. So we will take standard anterolateral approach with raplet fixes, and that can be addressed and fixed. Because that doesn't need any elevation or anything. You can see there is a line. And the circle, in most posterior part, you can see the line is going completely posteriorly.
Yes, sir.
But it has not separated the lateral cortex completely. So it needs a raplet fixes. So the most posterior part of the screw will fix it.
This is what Harjot is saying.
Yeah. See, if you see the circle, there is a line going posteriorly on lateral condyle. Okay. Obliquely line. This line is going posteriorly. What I will say. If I have cursor. Yeah, you are talking about this line.
Yes.
You are talking about this line. But it is not displaced. It is in position. Basically, you have to address this elevation. Then you put a raplet and put a screw. And that will be taken care of.
Well, the most common problem is the plate positioning decision making.
Yeah, plate positioning. You keep a little bit posterior. So your one screw just over the head of the fibula will fix up like this. This condyle is in continuity. So you just elevate this part. Now there is the X-ray. So again, there is a suspicion that there is a lateral condyle fracture. So this is 3D CT, 2D CT and 3D CT images. Now you can see here, there is a posterior condyle depression slope. Again, commission depression. Anteriorly, there is no fracture. There is a slope. Okay. So it is a lateral condyle which is sloped posteriorly and impacted and depressed here. So everything is behind the fibula head. If you see this. Okay. So here also you can see in this cut. See, if you draw a line anterior to the head of the fibula, everything is behind the head of the fibula. So this needs direct posterior approach. So what happens? Suppose somebody says, no, I don't want to go posteriorly. Just he wants to go anteriorly only. So he has to go anterolaterally. You have to break the intact cortex. Okay. And open the whole door. Then elevate it indirectly because you can't see posterior articular surface too much. Even a suprafibular approach with total meniscus azotomy, you can see it completely, but you will not be able to fix it as you want to actually. Then put screws. This is the most posterior part of the screw because behind that you cannot go. So your depression cannot be addressed. So even if you elevate full pillar, you will have a secondary collapse because there is not a good support of the implant. So better to go directly posteriorly. You can see the articular surface like this in front of your eyes. They elevate it, buttress it, feel it, and plate it like this. So your plate will be exactly like this by the side of the facet of the fibula head. And here you have to go malleable T-plate, 3.5, no sturdy T-plate here. And put 2 screws. Still you need only 2 screws, that's all. And the plate position in lateral view, posterior view, and end-on view, like this. And in CM image, you will look like this.
What is the approach here?
Posterior direct. This
Direct.
is the approach. Direct posterior approach. Prone position.
Prone.
Yeah, prone. Prone. This is the articular surface I could see. I elevated I fix up the plate. I put 2 screws. I left the center screw. I put 2 screws distally, 4 screws, and this is the elevation I have achieved. And that's the follow-up and full function. So that type of impaction are best managed directly by simple posterior lateral approach and put up a plate and elevation. That makes life easy. Simple. You can address the problem directly. Indirect fixation and reduction will not give this much access to the article surface. That is the only thing.
And it will not buttress the broken metaphyseal piece also. It will not support.
Yeah, posteriorly it will not, anterior, the lateral plate will not support.
It won't buttress it.
It won't buttress. It will allow the collapse, secondary collapse.
Yeah.
So better to go there only. It's better. Direct address is a simple procedure. It's a mindset to go, not to go, something like that.
How often you have to do a fibular osteotomy if the whole depression is way behind the fibula?
Sir, as far as possible, I avoid the fibular osteotomy. There are some implications about it. We have to tackle the common problem now too much. It can go for palsy, one thing. Second thing, there is a posterior corner will be whole disturbed. If you elevate whole fibula, it takes a lot of blood supply in that area also, and quite damaged. But sir, we can go by Frost approach, anterior, posterior to fibula head, and it's quite easy, and we can do everything without damaging anything.
So you hardly ever do a fibular osteotomy?
I have never done it, sir. Twice I did. I just fibula head was already fractured, so I just took out the fragment and I just did it like that.
Okay.
But I don't deliberately do it the osteotomy.
There are not many people favor a fibular osteotomy nowadays. Once the modified Frost and this direct posterolateral has come into vogue,
yes, agreed.
osteotomy is almost given up.
Yes, sir. Because we don't want to tackle the nerve and all these things in this approach.
If at all, I want to go posterolateral and anterolateral both, I will put a patient in lateral position and use a modified Frost, which allows me to put a raft plate anterolaterally and a distal radius plate like Jignesh has done posterolaterally by the same approach. It's a huge incision, big incision. Yeah.
Yes. And second thing, you can increase the access of this approach by doing lateral epicondylar osteotomy from femur. That will give more access.
Nelly, I think please, I'm not talking about the false approach where anterior posterior. I'm talking purely posterior fracture, depression, which is far too lateral behind the fibula, where you will still try to do it from posteriorly by the side of fibula. Am I right, Jignesh?
Yes, sir.
Yeah. Yes, sir.
Yes, sir. I will do like that only.
Because there is no question of anterior part at all here.
Yes, sir. I agree. Understand. But sir, you will be able to make the reduction properly and fix it without fibular osteotomy. I have never done it, sir.
Right. Carry on.
Okay, sir. Now, I always tell medial condyle is a mysterious medial condyle. So now see, this is simple medial condyle fracture total with posterior apex. So this fracture was understood rightly that it needs posteromedial fixation, but did wrongly. Anteromedial to posteromedial, anterolateral to posteromedial screws are fixed. And you can see the outcome. It is totally wear out. So it is better to choose the right technique and right implant for the fracture type. If we do something wrong, then the outcome can be really disastrous. Another one. Person understood the fracture very well, but he executed with 4.5 plate. Plate is distal to the apex. So it is not supporting the condyle. So it has collapsed with the plate. So none of the screw was fixing the condyle proximally. So again, inadequate fixation, improper placement of the plate, even after open reduction, it can give a disaster outcome. So these two are very important things, that your first screw should be at the apex, your plate should buttress the fragment completely, and you should have perfectly placed screws in the proximal fragment. You can't leave the proximal screws. Otherwise, it will allow the secondary collapse. I just put up this example because to understand the importance, if you don't do properly, we can get a bad outcome.
Sir, one question, please.
Please.
Sir, according to the buttress concept, sir, the screws in the proximal fragment is not required according to the buttress concept, sir. It is only at the apex you
that
put
is
one
only for an
cortical screw.
anti-glide plate when you use for the fibula or some other small bone thing. But a large medial condyle, we don't use it as an anti-glide or something like that. It is a shear fracture, so we use a buttress plate. But this fracture needs definitely a solid fixation. Dr. Tanna sir will agree.
Doctor,
Yes, sir.
even what Jagnesh is pointing out is an anti-glide plate while fixing the lateral malleolus in a trimalleolar component.
Yes, sir.
Even 25-30 years back, we used to put anti-glide plate and fix the distal fragment also, and that is the norm nowadays.
Yes. Agreed.
Carry the impression that if you are putting an anti-glide plate, you don't have to put screws in the other fragment. It can still rotate.
It can rotate and it can displace
Yeah,
also.
and it will be displaced.
That adds stability
Yeah.
to the construct.
So nowadays nobody does screw. Any anti-glide or buttress plate without screws. Nobody is doing it. Even in distal area, solar button also we fix up the distal screws. Because I have seen if you don't put the screw, it will collapse.
Okay, sir. Thank you, sir.
Yeah.
Doc, one more thing. That posterior malleolus which Jignesh ji was talking about, it's an intra-articular fracture. So you have to reduce it anatomically. Anti-glide plate is fine, but you have to really leg that fragment to the anterior intact cortex. Treat it like any intra-articular fracture. There has to be one leg screw in the distal fragment going across. And that applies here also. In the anti-glide plate.
This fracture which is I'm showing,
yeah,
it is actually two-plane fracture.
Yeah.
This fracture cannot be treated with a single plate or a single plane fixation. I will show the example later on.
Yeah.
I will come out with all the solutions. So this is bicondyle tibia with posterior condyle. Still we are with the problems. What happens? This is standard fracture. You will see two bicondyle fracture, and one is posterior condyle, one is anterolateral condyle. So this is the same scenario here. You can see, read to this is posterior condyle, coronal see complete large fragment, and this is lateral condyle. Again here it is lateral condyle. You follow my cursor, and this is medial condyle, posterior condyle, right? Intra-articular, and that is the shaft.
So here also in lateral condyle there is again a transverse line.
Yeah, there is some fracture is there. So it is a comminuted fracture, and that this posterior line is probably here. This is the line. This is the comminution it is showing. Okay. So, and this part is this part. Tuberosity and this anteromedial condyle is. So what is the template? Template is this anteromedial condyle and whole shaft tibia. So how will you start? We cannot start laterally. Whenever there is a medial condyle fracture, you start medially. That is a by and large rule. And so you first go with medial condyle. So my plan will be, I will go posterior approach. I will reduce medial condyle 100% with this shaft. So this shaft will act as a template. So with shaft, this posterior condyle will reduce and fix. Then make the patient supine, and I will go laterally and put a RAP plate. That should be my plan. Here, what surgeon has done, let us see. He did anteromedial plate. Both anteromedial and anterolateral plate. He did not understand that this medial condyle needs posterior plate. So this is what happened. Everything is subluxed. You can see whole femur is with this. Whenever there is a displacement, the femur goes with posterior condyle. Take it from me. Because MCL is here attached. Here. So it is a strong attachment of medial epicondyle femur to the medial condyle tibia. So, and it has very strong attachment of meniscus with it. So femur always goes with medial condyle. And if it is a posterior medial condyle, it will go subluxed posteriorly. So femur doesn't leave this. So axis is, this is the axis. Femur with medial condyle. So we have to, axis of the lower limb can be set by fixing this condyle anatomically with the distal shaft. Otherwise, it will not be properly fixed. Not possible. So we have to get this thing right. So it is very important to understand this. So you have to get this apex perfectly well, 100% reduced with this shaft. Then the axis, here, everything is posteriorly displaced. Subluxated. This tibia is whole anteriorly. There is a quite big subluxation. So you can see here a medial condyle because everything is behind posteriorly, down. Why it has happened? Because Anteromedial plate screw go like this. Lateral plate screw go like this. No screw can fix this condyle indirectly. Not possible. Whatever we do, but none of the screw can fix this condyle. This is not a very old case. I am showing is a very recent case. Just before 2-3 years. It happened in Surat only. So this is what happens. So what happens? Anteromedial plate for medial, posteromedial condyle doesn't work. Not a good idea. Lateral plate, none of the RAF screw can go posteromedial. Whatever angle you give, even with a variable angle, it will not catch this fragment. So indirect reduction and fixation is out of question. If you see posteromedial condyle, it dictates the posteromedial approach. That is the thing. So see, here this lag screw cannot hold this. It cannot pull the fragment. Not possible. It is a shear fracture. You have to buttress from behind. Otherwise, it will not correct the subluxation. The whole condyle is out. And the femur is also out. See, this tibia is anteriorly out, not under the femur. So femur goes with this fragment. It is subluxated posteriorly. It is always like that. So very important to understand this. So best idea is go directly posteriorly, fix it, reduce it, fix it with simple plate, and you can get this fracture. With very stringy simple plate. This is a very old case I operated. I initially in 2019 I was using this T plate. At that time this posteromedial plate was not available probably. Then this plate has entered and I have changed over from this plate to that plate. I was using this 3.5 plate only. So I started posteromedial condyle operating from 2008 or 9. First time I understood this fracture like this. So before that I was not knowing about it. I was not aware about it. Such type of fractures can occur. Frankly speaking. Everybody has a learning curve. So I had also a learning curve. So I learned like that. Then but I got an idea that this is the best way to do it. See the plate, perfect contour and this reduce 100%. So this is the best way to tackle posteromedial condyle or medial condyle with posteromedial apex.
You do it in posterior, which
always
position,
do prone position. Prone is best and safest. Simple. See, medial condyle reduces best in extension. In supine, figure of 4, you have to flex the knee. So the moment you flex it, you will lose the apex reduction, you will lose crumpling of the condyle and everything. All struggle, why to do this? Prone position, you are just in a commanding position. Put it in prone position, take a simple approach. Directly everything in front of your eyes. Just give traction and reduce and fix it. Simple. Why to make life difficult? Unnecessary.
Through the same approach, you apply anterior medial plate also.
See, if you are doing a prone position, anteromedial plate is not possible. But if you want to do both simultaneously, then I do in a supine with extended medial approach. Then sometimes I may cut the pass also, or I retract the pass by dissecting quite proximally. My incision is quite proximal up to medial epicondyle of the femur and distally also. And then I dissect out everything and then I go. But still, you will not be able to reach to the central part of the medial condyle. But I can do posteromedial and anteromedial simultaneously. I have done few cases, but I have not put it here because it just goes a little bit out of this scope. So I kept it for a little bit difficult cases like
Jignesh bhai.
Yes, sir.
The question doctor is asking, many times I do the posterior medial buttressing with the type of plate which is available from Synthesis and Indian company, sturdy plate, which you are using now. And then the medial one, even without cutting the hamstrings, I will probably put over the medial quarter. That second plate, the same flap is dissected and you can put the medial to lateral. Yeah.
Every time I don't cut the hamstrings. Sometimes you need to, if you want to go too much far posterior.
So the incision is same. You dissect out that flap and maybe put your plate over the hamstring also.
Yeah.
Slide beneath, whatever is.
I always put it beneath.
Yeah.
I don't put over the hamstring. I put over the MCL, but not over the hamstrings.
Yeah.
So when you went in.
Yes, sir.
Jignesh, may I ask?
Please, sir.
Please, sir.
Suppose if we do a posterior medial incision, you can create two windows, one above the pes anserinus with a stripping on the from the anterior side, and other window from the posterior side. You can strip it.
You can do either way and do it, fix it. Anteromedial and posteromedial simultaneously. But then you will be in a supine position, not in prone position.
Yes, yes. So with this, it is possible to do the plating on
Yeah, it is
posterior
possible,
as well as on
definitely.
the medial.
Sir, I have done a number of cases like that when I need both the condyle fixation, anteromedial and posteromedial.
Thank you, sir.
Simultaneous.
So when using prone position, because I have now switched to prone only, but many times PES doesn't even come. So am
In
I
prone position,
missing
base will not
something
come.
or?
You will, in prone position, you will see only one tendon. This is semity.
Yeah.
You will not see any other pass. But when you
So
do
here,
you will see the whole pass.
so in this CT also, in the above slide in the axial cut, there is a posterolateral, because I often get confused whether to fix posterolateral part or not. Like here
Sir,
also
this,
in the above right
this
corner.
is a very simple posterior condyle which is not going to collapse and not depress also. It is 1 or 2, 3 millimeter depress. I will ignore it. I will just fix posteromedial condyle.
Okay, thank you, sir.
And Jagnesh,
Yes, sir.
if I can add up, which you
Yes, sir.
directly,
Yeah, please, sir.
the reduction of this posterior median,
Yeah.
basically this apex and the side, you will have to match it because it is always a long piece or a big piece there.
Yes, sir.
Hardly ever go intra-articularly and try to see the reduction.
No, I don't see intra-articulary. But sir, when there is an anteromedial and posteromedial condyle, I split the MCL in the center vertically in line with the fibers, and I see the fracture line that it is matches perfectly.
Okay.
That is possible to do it.
Yes, sir.
When I am in doubt, there is a lot of commission lower down, and when I am in doubt whether I will reduce it or not, then I split MCL vertically in line of fibers, and I can see that reduction of articular fragment exactly in the center.
But that will be needed only if the medial fragment.
Yeah. Otherwise not.
Jignesh, sir.
Yes, sir.
May I ask one question?
Please, sir. My pleasure. We are discussing the thing, sir.
Very good to join Jala.
Yes, sir.
Yes, Sampla. Case is over.
Case is over. When you put a posterior plate, sometimes it is possible that our screw is coming in the main fracture line. So how to judge that? And sometimes then what will happen? It creates a difficulty in reducing the other fracture on the lateral side. Sometimes it is possible because you cannot pass through and through screws. We have to keep the short of the screw so that the other fracture should be also reduced properly. Then you can replace the screws. So what is your take?
Yeah, sir. Posteriorly, you see the attachment of semimembranosus. The posteromedial condyle. You follow my cursor. This is the attachment of semimembranosus here. This is semimembranosus. This is PCL. This part of PCL is here. My plate will be lower than this. Upper end of the plate will be here only, not here. So if you give plate here, then you will not have that problem because your subchondral screw from lateral side can be easily accommodated. Second thing, this posterior screw may not be bicortical. So I always just drill the near cortex and then keep the endpoint bony with the depth gauge and put the screw. That's all.
Jignesh bhai, one more thing.
Yes, sir.
When we are doing in the prone position and fixing posteromedial by anti-glide plate,
right, sir,
the radiology is slightly different what people are used to. So in the early cases, I ended up on table, I was happy, but finally the post-op X-ray showed some varus. This was
that happens with a bicondylar. I will show why it happens.
Yeah, sir, so you have to correct that by lifting that fragment.
Yes, sir. I will show the case why it has happened and how I learned it. I will show that case is there inside.
Yeah.
So in sequence, it will definitely come like that. Sir, everything, all questions and answers will come in this whole lecture. Everything will come. So this was the situation. So I applied a posteromedial approach and I put a plate like that. So picked up, and so plate is this fracture, lateral plate or medial plate doesn't work. Only posterior plate works. Now, we have to identify the medial condyle where it is. Both are medial condyle fracture, but this is sagittal plane and this is coronal plane. So sagittal plane fracture needs just medial plate and fixation. Coronal plane needs posterior plate and fixation. Both, but we have to change the surface of the plate, where to put. So understanding the condyle in sagittal or coronal is very, very important to decide your approach, to decide your implant and placement of the plate on which surface. and that will make the things perfect. Another one, identify the medial condyle, right? One is, this is CT scan C, coronal plane fracture. See, intra-articular medial condyle fracture, then large apex, right? So here also there is a double line, and there is apex. See, this is medial condyle. This is classical presenter. This is, if you see this apex, in later view means medial condyle. Even if APA 100%, I will say it is medial condyle. Another one. Okay, this is total medial condyle. See, it is bridge here, and there is no fracture here. See, this is total medial condyle. This is very dangerous fracture. This is concept fracture. This will go into RS, sir. Sir, this will go into RS.
Yes, sir.
This will not go into RS because it is coronal plane fracture, medial condyle entirely intact.
Yeah.
But this total condyle fracture, like this. See, actually this fracture is proximally, it is sagittal plane fracture. Distally, it is coronal plane fracture. So this fracture needs fixation in two planes. Posterior anterior, medial lateral. If you don't neutralize in two planes, this will go into RS. So I will show the trick, what we are doing it. Okay. So here, standard coronal plane fracture, like a volar Barton. This is volar Barton of tibia. This fracture is volar Barton of tibia. Just put a plate and get out. That's all. But here, I did 3 plates because there was a posterolateral impaction also. So I elevated it. I opened this window, elevated, and then fixed the posterolateral plate. And then for this condyle, I had to do double plating, medial as well as posterior, to neutralize the varus. I will show this case as a sequence of IRTV image, how it has gone into varus.
Jignesh, that patient was done by a single extended posteromedial, I believe.
Single approach.
All 3 through a single incision. Yeah. In the prone position.
Yeah, single incision.
Yeah.
In prone position. Yes, sir.
Yeah. With gastroptenotomy.
Yeah, I will show you complete case. Later it is coming next.
Jignesh bhai, by single incision, how far you can go laterally?
Sir, you can see 85% of posterior surface of tibial condyle.
Just near the fibula, it is impossible.
Yeah, you cannot go beyond the fibula head and near the fibula head. You can see complete medial condyle, you can see complete PCL, you can see half of the posterior condyle. This much you can access with tenotomy of the middle of gastrocnemius. Easily, sir. This can be easily seen. थोड़ा हिम्मत करना पड़ता है, हो जाता है. और सोलियस को सोलियल लाइन से उठा देने का तो बराबर हो जाएगा एकदम मस्त. So now we understand this medial condyle. I am still on medial condyle.
Can you repeat about the soleus? What did you say?
We have to erase the whole soleus from the soleal line of the tibia distally to reflect it completely to go to posterolateral surface.
Yeah.
तो जिग्नेश भाई तू इतना सिंपल बताता है कि इट इज वेरी डिफिकल्ट फॉर अस टू एग्जीक्यूट, और जब करने जाते हैं ना
सर अपन एक दिन कैडेवर रखते हैं.
हाँ,
अपन एक दिन कैडेवर रखते हैं. कैडेवर एक बार अपन वी विल डू कैडेवरिक वर्कशॉप एक बार. मस्त मजा आएगा उसमें बराबर हो जाएगा.
Can you get this cadaveric thing on this course?
We can put cadaveric course like that.
No.
Approaches around tibia.
What I'm saying is, to this crowd, can you show? See, I think Dr. Chandok showed beautifully on the cadaver surgery. Can you show this to this crowd on the cadaver? These approaches.
This approach, sir. I have got a live surgery approach.
So you can show those live things.
Yeah, after this talk is over, I will show the video.
Perfect. Jignesh, I want to say one thing.
Yes, sir. Please.
I must have heard you at least 15-20 times.
Yeah.
And every time I hear you,
I
learn something. Terrific it is. Thank you very much.
Yeah, please, sir. Thank you, sir. 2 different types of fracture as per mechanism of injury. See, medial condyle has. See how the medial condyle fracture occurs and how it goes. There are 2 types of fracture. One is extension type fracture. So varus force in extension and varus force in flexion. So varus force in extension means simple fracture. It will have apex anteromedially or medially. Just give traction, it will fall into place just put a medial plate, intercondyle screw and over, right? But varus force in flexion means dangerous injury. In flexion, there is a varus force. Each patient will have 3 types of displacement. Each will have, you can see femur condyle with the medial, femur condyle is with the medial condyle, impaction of the posterior condyle by the lateral femur condyle, and ACL avulsion and subluxation of the tibia, tibia anteriorly from the femur, because femur goes displacing posteriorly with this posteromedial condyle. So varus force in flexion is a bad injury. Varus force in extension, simple injury. It just causes a medial condyle fracture. So both are medial condyle fracture, but they need different type of treatment. And if we treat varus force in a flexion injury like an extension injury, we can have a bad outcome. See. Yes, sir.
Can you explain in extension and in flexion and extension that maybe you are describing, but it doesn't tell you that I fell in flexion or extension. So from the
sir, if the apex is posterior, it has to be in flexion. In extension, apex cannot be posterior. In extension injury, medial condyle will have anteromedial or medial apex. It cannot have posterior apex. Or posterior coronal plane fracture cannot occur in extension. It will occur only in a flexion force when the femur condyle in flexion pushes and bangs the tibia in a medial posterior half of the tibia. So it causes medial condyle or a posterior medial condyle, posterior condyle, and subluxation of the tibia anteriorly so much that it will avulse the ACL. This is the pattern of injury, classic. Always it happens like this only, sir. So whenever there is you see anything posteriorly, means injury force was in a flexion, not in extension. This is very much classical, sir. This is always, it goes like that only. And it needs coronal plane posterior approaches. See, this injury, second injury, is classical varus force in flexion injury. It has got, see, medial condyle fracture with apex, which is posteriorly. See here, posterior. There is a central impaction of the lateral condyle by the lateral femur condyle, and there is a subluxation anteriorly of the tibia because of the ACL injury. And if the same injury is treated like an extension injury by medial plate, varus cannot be corrected, posterior displacement cannot be corrected, everything. See, this widening cannot be corrected. The tibia is totally anterolateral subluxation is there. So, see, this is only a plate is inside. Otherwise, injury is same. It has not reduced anything. It has fixed the fracture in a displaced position only. So, this anteroposterior screw can never hold this medial condyle. Not possible. Anterolateral posterior medial screw. No meaning of putting this screw like that. So, this fracture actually requires first posterior medial approach, corrects everything here, reduce this, and then anterolateral wrap plate. We have made it perfect. Absolutely. This is a simple fracture. It can be 100% reduced and fixed nicely.
Jignesh bhai.
Yes, sir.
In this type of pattern which you are showing in this case,
yes, sir.
This surgeon has really messed up. This is not the way. The surgery will be done like as you advise, posteromedial and reduction and everything.
Yes, sir.
Still, at the end,
yes,
surgeon might be left with some widening of the tibia, so which is very annoying.
Yeah.
So how do you reduce that widening of the tibial plateau? If you look at the normal plateau, that also in those patients is slightly broader than the femur. But on this side, you have got another 5 millimeters. On the normal side, 5 millimeter widening. On this side, you may have 8 or 9 millimeter widening. So how do you reduce that widening? Whatever you do, it doesn't reduce. When all the fracture lines are normal,
that is. Sir, I tell you what happens. What happens. You reduce this, okay?
Posteromedial.
You don't forget to clear this central area. If you don't clear it, it will not allow this condyle to go in.
Okay.
So when you do posteromedial fixation, clear everything in this central impaction portion, posteriorly.
What do you mean by clear?
Clear means I will remove all the loose small fragments outside. Take out.
Take out.
Yes, take out. Because they are useless there. They are not doing anything except occupying the space there.
Okay.
So and it is not an articular fragment portion. So posteriorly, it is not getting reduced. So when you compress from anteriorly, it is not getting reduced because these fragments are coming in the way.
So when before reducing the posteromedial and putting an anti-glide,
I will
clear out that area.
Yeah, we clear out. You put posteromedial plate. to clear completely here that all small fragments which are intercondylar region. Okay, the small pieces of the cortex and all these things you take out. You can use as a graft underneath the elevated condyle of the lateral side. From lateral side. Okay, if needed. If needed. Or if there's a big void, you put it down, lower down. But don't leave anything in the top area. If you top layer leave this cortical pieces, they will not allow the reduction of the lateral condyle.
Yeah.
That is the problem, sir.
Yeah, that happened with me.
Yeah, this happens.
Yeah.
Jignesh, why it is sometimes it is very difficult in the coronal split. There is a spicule which precludes the widening to be compressed, and in such a situation that prone fragment remains so inside, it's a very difficult to remove it. And sometimes we have to accept by default some widening.
Yeah, sometimes it happens. You are helpless. You cannot do anything. But this is what, sir, we learn by the experience gradually. That's why it has happened like that.
Gadigona Sahab, he is giving a very useful tip that you push, either take those pieces out or you push them down in the canal, metaphysics.
Yes. That is the only way to get proper reduction of the proximal part. Otherwise, these fragments will not allow you to reduce it.
जिग्नेश भाई का मैं विद्यार्थी हूँ.
अरे सर ऐसा मत बोलिए. आप मेरे गुरु हैं
भाई.
ये चेला सब गुरु के सामने प्रेजेंटेशन कर रहा है सब. I am absolutely humble and down to earth for this. And my mentor is there sitting and hearing me. So I am very, very glad to have that situation. Okay, sir. Should I proceed?
Yeah.
Sir, I have a question.
So varus, subluxation, posterior depression, everything is like that only. Nothing is corrected. So not a good way to treat this fracture like this. So again, the total medial condyle with posterior apex treated by medial plate. Again, not a good idea. I am just putting the example that if you do wrong, what will happen? If you don't do the things in the right way, this is the outcome. So we should not do this type of fixations, and we should understand the fracture pattern very well, understand the fracture geometry very well, and then put up a plate in perfect position. Another one. I am just getting the examples. So again, this medial condyle, lateral condyle is fracture. So surgeon selected the lateral approach, tried to fix up the medial condyle from medial side one screw and this. But you can see he could not reduce the posterior medial apex. This apex cannot be reduced and held by any of the anterolateral plates. Not possible. So we should always address this. We should see this. This has dictated your approach. You have to go posterior medial. No choice.
There is a reversal of the slope also, Jignesh bhai, here.
Yes, here it is. Reversal of the slope also, it is also there. It has tilted completely. See, this apex is totally open, so it has gone up like that. Again, this, see, medial condyle by hockey plate. This is again a bad implant to use on medial side. Hockey plate cannot work on a medial side. It is designed for lateral condyle, lateral side, lateral surface. So again, see, same thing. The pre-op and post-op picture is same. Only plate is there inside. So this is what happens if we don't understand the fracture very well and don't use. There is nothing to criticize anybody, but I am just telling the fact that this type of fracture, you need proper understanding and proper execution of the procedure to get a perfect outcome. So we should understand it very well by doing CT scan and all this thing. Where you see the apex, what is the condyle, where is the position, then plan your surgery properly and then fix up. See this condyle, again I tell you, proximally it is AP plane fracture. Distally it is coronal plane fracture. So here it is buttress, but here it is mediolateral screw or fixation. If you don't do two plane fixation, it will go into varus. This will not get corrected. We have to correct this. Then this apex will come here. This apex arrow is here. It is laterally. It has moved like that. So this is total medial condyle with. So I call this fracture as a double apex fracture. These are double apex fracture. This. It is medial apex. It is posterior apex. So
sir, one question.
Yeah, please.
Sir, in such type of fracture, which plane you will fix first, sir?
Of course, I am coming to this. You will see the sequence and you will understand.
Okay, sir. Thank you, sir.
I am giving your answer only. Next case. This is same fracture, total medial condyle fracture with double apex. This and this. With medial and posterior, there is a ACL injury and there is posterior impaction. I will show you. There is some infection here. This is ACL injury. This is AP plane medial apex. This is posterior apex. There is ACL. There is a posterolateral small fragment in medial half only, central part. And that's the complete medial condyle fracture. There is no coronal plane fracture in a medial condyle. And you can see the complete fracture. See the apex here. Complete medial condyle. And this posterior apex, and there is medial apex, right? Okay. So everything description is done and all X-rays are read properly. X-ray, CT, everything is done.
Jignesh bhai.
Yes, sir.
This ACL word is coming again and again.
Yeah, ACL is always there, sir. On all
No. It is there. Like, are we doing anything in the acute phase?
Sir,
For
yeah.
those small
Yes.
pieces, if it's
Yes.
a big one, fine.
Sir, for documentation, we have to put it like that. But it doesn't need address in most of the cases. In
Most
very
of
few
the
cases where
yeah.
there is a very large fragment, I fix with the screw.
That we can fix, or even the scope is.
No, I do transligament split and put a screw in large fragment. But in this small fragment doesn't need any fixation, sir, because there are very small, tiny fragments and bony pieces, they heal very nicely. I mean, post-operative, in follow-up also, I have not seen much of the ACL instability or any problem with the patient.
And Jignesh, it doesn't change our post-op rehab. We are equally aggressive.
Yeah. I mobilize them.
Yeah.
So let's, should I go further? So my plan is, go posteriorly, posteromedially, put a plate and get first screw at the apex. So I will first correct this posterior anterior correction, right? Then I will see my virus is there or not after correction. I will show you. And then put intercondylar screw. So first I achieve posteromedial buttress, get this apex inside. Once I have got this virus correction, I will go mediolateral fixation first. So I will get intercondylar compression proximally, right here, because this is a sagittal plane. And then I will put rest of the screws like this. Okay, so let us see the sequence now. I put on my plate posteromedially, and you can see the varus. Varus is there. I corrected varus by joystick. I showed the same tip in a Pune Sancheti surgery. Same fracture was there. So I corrected this varus. See, you can have see this varus apex. I put a joystick. I elevated it. First, I put the half K wire. I elevated and then fixed with the lateral condyle. And now you see there is no varus. Right? I put first screw. I put another screw. I put a guide wire from medial to lateral, but I put the screw from lateral to medial because I don't want to entrap MCL underneath the screw washer. So I keep 32mm thread or fully threaded screw from, I usually put partial threaded screw to have a compression, 32mm thread. So 32mm thread from lateral to medial. There is no proximal fixation till I get the compression between both the condyles. Distally I have got only one screw. Then I have got rest of the screws and fixation. And that is post-op X-ray. And that's the follow-up X-ray. You can see there is no varus. Straight condyle, intercondylar compression, no widening, nothing. So this double apex fracture can be addressed like this. So this is the trick. Double apex means, sir, you are asking, it goes into varus. This total medial condyle fracture can go into varus. So by putting first we have to correct coronal plane displacement at apex here, lower down. Once you correct that displacement, once you get this alignment perfect, then you check AP view, it will be virus. You can just put a joystick half wire and correct it by 2.5 mm wire. Once you correct it, draw this wire in the lateral condyle. It will maintain the correction. Then pass one more guide wire subchondrally, put a screw from lateral to medial side, 32mm thread. So it will cross the fracture zone, compress it nicely, then put rest of the screws in a locking board over. It will be absolutely perfect anatomy restoration. So another one, same fracture, same. Complete, but there is a more communication here. See, here communication, here communication, here communication is there. Okay.
Jignesh bhai.
Yes, sir.
The posteromedial plate plus in some cases we discussed that it will require 2 plates. One
Yeah,
in
I
the
will show you.
sagittal and one. So how do you decide that only 1 or 2 screws will suffice and you need a second plate? How do you decide that?
Sir, initially I used to put 2 plates, but
Yeah.
now I change over to single
Screw.
to avoid more dissection. 1 or 2 6.5 cc screw hold the things very nicely, so you can avoid medial plate. But if there is too much of combination on a medial border, then you add the plate. Again, same plan. First posterior buttress screw, then intercondylar screw, then rest of the screws. So here I have this gap. You can see the gap. Then reduced. Here I put a posterior plate, then screws. Then this is the screw from lateral to medial compression, and then rest of the screws. You can see this full function, and this is posterior fracture, and there is no virus. So again, we executed the same way.
Jignesh bhai,
Yes, sir.
when you put a posterior medial incision,
Yes, sir.
it is easier to do a compression from the medial side, and you advise to do it from the lateral side. What is your philosophy behind it?
Sir, screw from medial to lateral side will you will have to put a washer or some screw which will go through the MCL, and it can irritate the MCL fibers. So patient can have difficulty in mobilization. So I put the guide wire to get in center of the medial condyle from medial to lateral side. But I put the screw from lateral to medial to avoid that penetration on the medial side.
But that
I don't want to put an implant on medial surface. That's why.
But problem, what is this? You are putting from the solid surface towards the fracture surface.
Sir, this threaded person is here. It usually compresses. If you want an additional compress, you can put just pointed clamp and compress it and put the screw.
Oh, the principle of compression from the separate fragment towards the solid fragment.
By principle, you can write, but then your implant will be prominent on medial side.
Okay.
So I want to avoid that irritation and everything. That's why I put the screw from lateral to medial. If you are not happy with the compression, you can additionally put one clamp, fixing these two, compressing these two, and then put a screw.
Jignesh bhai, can I answer you?
Yeah, please, sir.
So, see, this is a buttress plate, but you are using in a bridging mode. It is not used in a buttress mode.
Yeah.
So that is why you have to supplement with additionally. Gadigone sir.
Sir.
Am I correct, Jignesh bhai?
Sir, this portion of the condyle, this is sagittal vein fracture here.
So if you have a apex, if you have a clear apex, not comminuted, you can use a buttress plate over that. But if the apex is comminuted, you cannot use the plate in a buttress mode. You have to use it in a bridging mode. Am I right?
Sir, every time we always fix up all the screws, so it becomes in a bridging mode only actually.
Okay.
Suppose there is no combination here, then also we fix up the same screws. There is a combination, we have fixed up the same screws.
Okay.
Sir, 2 questions, please.
We are just. I'll answer your questions.
Sangeet.
We are just putting this plate to get this anteroposterior displacement. Once you correct this, then you compress this condyle proximally intercondylar region by lateral to medial side. Because this fracture is in this plane. This lower fracture is in this plane. This condyle is a concept condyle which has intra-articular portion in a sagittal plane. But it has distal portion in the coronal plane. Apex is posterior. So this cannot be fixed by medial plate. It has to be posterior and medial both. So 2 plane fixation is required. So I do proximally this plane, distal is this plane. You can put here a plate. I will show the case. I put the plate on medial side. But gradually, by doing more and more cases, I did 5-7 cases with plate. Then I did this screw cases will be more than 15-20, and none of them has collapsed. So I thought that medial plate is not required. You can just get away with the screws, and it can hold your reduction very nicely. Because once you reduce this locking screw also support this condyle, it will not allow the collapse. So you can avoid one plate by putting one screw, that's all. And you can get the same compression and same outcome and result by putting one medial or additional screw in a different plane. That is what the idea is. So just to avoid one plate, reduce the number of implants and number of the screws, I started doing this fixation because proximally you need this portion here, each compression like this. It is complete medial condyle fracture.
Sir, few questions, sir.
Please, sir.
Do you put first cortical screw
Hmm?
at the apex?
Yeah, first screw is cortical. To
This
compress
one.
the plate and get the sub, yeah, this one. Then
Okay.
locking or compression, anything will be okay according to the age of the patient. If young patient is there, you can use all cortical also.
Sir, few questions,
Proximally
sir.
all locking.
All locking.
Proximally all locking. Proximally don't put cortical and don't put the condyle back to the plate. Huh? Don't
Sir,
do that.
Sir, few questions, sir.
Doc,
Please.
can I add something here about that screw?
Yes, sir, please.
First screw pass in the oblong hole at the apex of the fracture.
Yes, sir.
I use a cannulated screw because when you are passing from posterior to anterior, that first screw, you often get lost and it doesn't bite the anterior cortex where you have drilled it. So that first screw is, for me, is always a 4 mm cannulated screw. So
इतना psychomotor skill develop कर लेगा सर ये लोग
Yeah.
कर देगा direct.
Yeah.
बराबर है चलता है.
और बड़ा रहता है वो उसको बदलना पड़ेगा. You will have to
Yeah.
change it.
Yeah, you have to change it every time.
Every
I always
time.
select little bit larger screw, longer screw,
Yeah.
and I am going to change it. Sometimes I replace that screw with the locking screw also if possible. Sometimes.
Sir, few questions, sir.
Please.
Sir, number one question, sir. How do you prevent the condylar clamp which you put? Sometimes it goes into the lateral condyle because the bone is soft as compared to the medial. So how do you prevent the condylar clamp? The
You
clamp
can
going
use
into the
a, you
lateral.
can use a ballpoint clamp. So ball will be bigger, so it will not enter in the condyle. It will work as a washer.
The spike of the ball point is sharp, sir. It goes into the.
That much is 3-4 millimeters, so that doesn't matter much.
Okay, sir. In this case, sir, there is some compression on the middle side, sir.
Yeah.
Another tip, you just use a washer over it,
Washer over it.
on the lateral or medial wall, and then
Yes, sir.
ball tip so that it will not go inside.
Yeah.
No.
Second
Sir,
thing.
sir, second question, sir. In this X-ray, sir, there is some compression on the medial side, sir. So, what was, sir, if we have put a plate, sir, on the medial side, sir, 2 plates, sir.
Yeah, that is also good enough. Fair enough. Nothing wrong in it. But I wanted to avoid another plate. That is what I am saying. I just got away with this and see, it has not collapsed.
And sir, third question, sir, there was.
I mean, you can avoid middle plate by putting another plane fixture with the screw. That is what the idea is. See,
Okay.
Most of the time, you want to reduce one approach and one plate.
Okay, sir.
That is the thing.
And
If
sir,
everyone can do it, then it is good for the patient, for surgeon, everybody. It reduces operating time, it reduces dissection, it reduces morbidity, it reduces implant costing, everything.
and sir, last question, sir.
Produce the same result.
Yes. Sir, last question, sir. Sir, there was some one video on OrthoTV, sir, that of putting tense nail to the middle condyle, sir. Of
Femur.
Yes, sir.
वो सब टेल स्नेल वगैरह बेकार है.
Yes, sir.
Yeah.
He's saying it bekar hai wo.
I cannot repeat it again. सब बेकार है, वो टेस्ट वेस्ट मत किया करो.
ठीक सर. नहीं सर, वो OrthoTV में खुद ही वीडियो था इसलिए सर पूछा.
अलग अलग रहता है, अपन कुछ क्या लेना क्या नहीं लेने का वो अपन ने सोचना चाहिए ना. तलवार लेने का कि धनुष्य बाण लेने का.
जी सर, जी सर.
Sir, can we proceed? Jignesh?
Yes, sir. I'm going to next. I've already gone. So this is a medial condyle fracture. Classic what we have seen right now. Okay. But here you have to see this. My cursor. Anteromedial commission is there. Don't ignore this. Okay. Surgeon has done this. He did posteromedial approach. But see, his apex screw is here. His 2 screws are at the apex. Could not reduce the condyle properly. It could not correct the varus, and same thing has happened. He did all anteromedial too, and he has seen these my cases, all these things. After that, he has done this. So this thing happens. So you understand it well and execute the procedure properly. Otherwise, and wrong plate is used. See, this 4.5 plate, very sturdy. And see, this simple fracture actually, but could not be done well. And see, enteromedia, everything, like a pre-op X-ray only, worse than pre-op X-ray. So, understand the fracture well, execute the procedure very well, put a plate at a perfect place. See, so management changes with the time. So, this is the X-ray of 1987 Surgeries textbook, and this is our X-ray. Same fracture. See, condyle is gone in, medial condyle with femur like that, tilted. Same. He has not shown lateral view. But see, they have done medial plate at that time, in that era. And you can see this is not reduced. They use one plate medially over the condyle and then put 2 screws out of the plate. I think, and approximately there are no screws almost. So, it says it is okay. That is the treatment shown. Okay. And we have got the same thing. At that time, they did not have CT scan. We have a CT scan. So, this is PCA fixed fragment with medial condyle. And this is the simple plate posteriorly and PCA screw. So, the management changes with the time. So, it took about 30-35 years to change the plate position from medial to posterior surface for a medial condylar fractures with posterior apex. So, it took a lot of long time and thinking to change over the plate from this surface to that surface. Now, this is comminuted medial condyle. Subluxar condyle. Right? Now it has got anteromedial condyle, posteromedial condyle. Okay. And there is a PCL with this fragment. And anteromedial condyle is totally out of the, see, femur is with the posteromedial condyle. See, you can observe that. This will not be out of the joint. Joint is here. This tibia will go out. It is always displacement. You observe now, all the cases. The displacement will occur like this only. This will go out. If it is intact, then it will go with the shaft. Femur will not leave this fragment. That is for sure. 100%. This is very strong attachment of PCL as well as this fragment with the medial meniscus posteriorly. Very thick capsule and everything is there. So this is usually pattern. And that is the lateral condyle, which is subluxated anteriorly out. Okay. Now, how to go about it? So what I did, first, I just gave traction and got the reduction of the anteromedial condyle perfectly on the medial surface. So I got percutaneous reduction and put anteromedial. Whenever both the condyles are there, anteromedial and posteromedial, first reduce anteromedial condyle. Because template to reduce posteromedial condyle is anteromedial condyle. If anteromedial condyle is not reduced 100% with the shaft, the posteromedial condyle can never get reduced. So never make that mistake of reducing posteromedial condyle before reducing anteromedial condyle with the shaft. Always get that anteromedial condyle with the proximal tibia perfectly well. So there is a post-op X-ray. Posteromedial plate, medial plate, anteromedial plate, and you can get perfect slope, reduction, fixation, everything. And there are the posteromedial scar, and there is anteromedial percutaneous plate. Here I use that anatomical medial plate, posteromedial plate on the anteromedial surface, medial surface, and then put 1/3 plate and this T plate on the posteromedial surface, PCL, and both the fragments are fixed. And that is the 2 years follow-up. Patient got implant removed.
Jignesh bhai. Jignesh?
Yes, you are not heard.
I think he has lost internet connection. Jignesh?
Yes, sir.
You are not heard.
Sir, I am there.
Yeah. In this particular one, which was really shattered, how
Yes,
could
sir.
you get perfect reduction anteromedially
Sir,
without opening up the thing?
I was prepared to do enteromedial approach, but the moment I got the traction, traction reduced it. So I was lucky.
Yeah, it fell down in place. Yeah,
fell down in place. So I just put a small pointed clamp on the enteromedial fragment with a lateral condyle and compress it. It got reduced. So I put percutaneous plate. So my work became easy. Otherwise, I would have opened enteromedially.
You are willing to do that.
Simple. But I was lucky to get that thing in position. So I did it like that.
Sir, that 1/3 tubular plate, which fragment it is compressing, sir?
It is on the posterior medial border, and this plate on the condyle. This plate was on the condyle, and this is on the border, and this. I have to go back. Sorry. Oh, we are going.
No, show us.
Yeah, this plate is here. 1/3 is here, and T plate is here.
Okay, sir.
Okay.
Every apex has to be buttressed.
Yeah, I think all fragment need fixation because otherwise it will allow the collapse. Now this is posterior bicondylar tibia, double plate for medial. This is Potocnik has described the same injury. He has described as a posteromedial fracture dislocation. So posteromedial tibial plate to split fracture, posterocentral lateral tibial plate to depression fracture, what we are talking about, and eversion fracture of the ACL. This combination may be called as a fracture triad of posterior bicondylar tibial plate. They already described long back, around 1980s or something. Now, what happens is how the fracture line proceeds. That is what I would like to explain. See, the fracture line of medial condyle can be from this, it shifts here or it shifts here. Okay. Now, these are the variations of total medial condyle and partial medial condyle. See, total medial condyle can be from lateral condyle. So, this is a medial condyle fracture, but intra-articular, it is a lateral condyle fracture. See, it starts from lateral condyle. It is lateral to the intercondylar eminence. This variety is there. So, it has always as apex medially. This variety fracture cannot have apex posteriorly. More the intercondylar line laterally, apex will be anteromedially or medially. The apex moves like this. This intercondylar line moves like medially. The apex is rotate like this. So, more the fracture is like this, apex will go like this. So, once this shifts from here to here, apex is shifted from medial and posterior. This is double apex fracture. This type of fracture will be double apex fracture. It has a medial as well as posterior apex. And this type of fracture will have only posterior apex. And all have ACL. ACL, here will not be ACL. Here it can have ACL, cannot have ACL. But here it has surely have ACL. This is the variety always. It follows the rule. It follows the fracture pattern exactly. Now, whenever you study this CT scan, you will see, and just make a note of it, you will see that it follows the fracture pattern perfectly well.
Superb.
It is the rule. Injury occurs like this only.
जिग्नेश जी,
यस सर,
ये डायग्राम आपने खुद ने निकाला है, बहुत सुंदर है।
नहीं, मेरा नहीं है सर, मेरा किसी आर्टिकल में तो उठाया है। मैं आपको बता भी देता हूँ उसका क्या मतलब। एक ऑथर है सर, उसका नाम है सिमिंग चैंग। He has described morphological classification of tibial condylar fractures. Beautiful article, worth reading. सिमिंग चैंग मेरा ये फेवरेट ऑथर है, बहुत बढ़िया है। उसने टॉकेटर के ऊपर भी बहुत अच्छा लिखा है, टॉकेटिक फ्रैक्चर्स के ऊपर, सुपर्ब है। His study is fantastic. उसने लिखा है morphological anatomy of the medial condylar fractures. He has described 8 variants of medial condylar fracture, 8 variants, and I have seen all the 8 variants very frequently. Exactly what is described, exactly it happens like that only. I am a great fan of him. मेरा कुछ नहीं है सब, मेरे सब कंपाइल किया है, मेरा कुछ नहीं है। I am nobody.
Jignesh bhai.
Yes sir.
We are all fan of Jignesh Pandya sir.
Thank you. Sir, मेरा कुछ नहीं है. मैंने सब compile किया. I have just understood this article and just put the things together to make it understanding and make it easy, simplified. Okay, sir. So this is the injury. Now this will tell you a lot of story. This is a very nice case. ये केस ने मुझे बहुत सिखाया है सर. मैं फंस गया था इसके अंदर. This is a bicondylar tibia fracture. Bicondylar means this is complete medial condyle. See, complete total medial condyle with sliding like this has gone to. It will go into varus. This pattern has tendency to go into varus. It has got a ACL eversion and it has got a posterolateral depression here. See, this is a depression of posterolateral condyle. So this is classic pattern. Okay, what we have seen. This is the injury. ये injury है वो. With ACL है. इधर ACL है. उसमें. Now I have done as my protocol. I did posterior plating. ये पुराना केस है बहुत. From where I learnt. Fix कर दिया उसको. ऊपर भी fix कर दिया. Confidence में के बराबर ही है. पीछे relaxation 100% हो ही गया था. So I fixed up everything. I did not check the AP view till I fixed up the screws. Okay, I opened up. I reduced 100% posteromedially apex and everything, and I fixed up all the screws. And I saw the AP view. It is in the varus. It is not reduced. So this fracture goes into this type of reduction. I learned from this case. Then I removed the proximal screws. And I just put a medial plate and got the reduction. See, I got the reduction on medial side. Right? Now I was in the lateral view. What happens? The plate is off. Because I picked up the screws and pulled the medial condyle, it has rotated and gone into varus. The moment I remove the screw, I reduce into varus, the plate is off. So I change the plate. Because now I cannot put this plate. I change over from this plate, T plate, to posterior middle plate, locking plate. And I left that cap as it is by putting the locking screws. Then I reduce from the same approach, this posterolateral condyle elevation. And I put one more plate. So I had now 3 plates, posterolateral plate, posteromedial plate, and medial plate. And that's post-op X-ray, not good quality. But this is follow-up X-ray of almost 8 months, 9 months, and he has full function.
All these 3 are also through the same single approach.
Same approach. Sir.
Single approach. Extended posteromedial.
Extended posteromedial.
Yeah.
Jignesh sir, may I ask one question?
Pucho sir, please.
Over the years, you have treated so many cases.
Yes, sir.
But there is some articular incongruity remains in spite of doing all these things.
Yeah, I agree with you.
Does
every time we don't say articular surface for reduction. True.
So, is there any correlation with that left out?
Sir, if there is a minimal in young patient and less than 5 millimeter depression on lateral side, it tolerates very well. I have seen most follow-up of the now I have got follow-up of 8 to 10 years and they have no problems. They come with other fractures, other problems also, but they are happy with that. But medial side doesn't tolerate well. If you do something wrong on the medial side, virus or some displacement, it doesn't go well. They pay heavy price. They go and they become painful.
Jignesh?
Yes, sir.
This part of the tibia.
Yeah.
You feel it is still depressed, it is not been elevated adequately.
Yeah. Sir, this X-ray, see, there is a double line here also and double line here also. Medial condyle. So this X-ray focus here only. If it would have been focused knee, it would have been perfect. And this lateral condyle was normal, sir. Only posterior part was depressed here.
This,
I will go pre-operatively.
This function which you are showing.
Yeah. It can come with depression also, sir.
Huh?
It can come with depression also.
With depression also.
Yeah, it can come with depression also.
Badly reduced fracture also it can come.
Yeah. Agree.
Fraction is not something which is the.
Yeah, agree, sir. Because this is most posterior part of the tibia. So it comes very late in the when patient sits full cross leg or full squat, then it comes in a contact.
Now here as you mentioned about if there is a big amount of depression in the center, then please go back. Please go back.
Yeah, I'm going back. Sir, there is no depression of lateral side. See, lateral condyle is completely intact. There is only a posterior rim was fractured, this most posterior part.
I'm just trying to tell you something.
Yeah.
There is a same X-ray which we were discussing. Can you go back to that X-ray, please? Yeah, this one. Now, if there is a depression already here, which is because of the comminution.
Yeah.
There are a few surgeons, I have heard it in the meetings.
Yes, sir.
Also, that they go down arthroscopically.
Yeah.
They do the articular cartilage transplant here.
Right.
Because
Right,
it was observed that these people will go on to osteoarthritis later.
Later, yeah, possible.
So they try to do this in this small area only. They try to do the articular cartilage transplant from the intra-articular area.
Right,
and
sir.
They have shown to be, after the arthroscopy, get the fairly decent amount of highlight cartilage or a fibrocartilage formed there in giving you a fairly decent surface. Now, still it is in an experimental phase, it's not been established yet, but this is what is being some of the.
Right, sir. Sir, you must have seen the longest follow-up of the patients. You must have seen number of patients like that in follow-up. And sir, how many patients require TCAR after tibial condyle fractures in a long run? Because of that tibial condyle fractures. There are very less number of cases comes like that.
Jignesh bhai, actually, as far as I know, I have studied that the Hall and Luck theory is that whenever the small articular depressions are there and split, they are filled up by a fibrocartilage.
Yes, sir.
It's not a hyaline cut, but it's a fibrocartilage. It's a very tough surface.
They work well.
Yeah, and therefore they are painless and they don't have a pain in the movements because that fibrocartilage and a very thin layer of fibrocartilage, they are a painless structure. And therefore, majority of this type of a fracture, when there is a congruency is disturbed also, they have a good functional outcome. And
right,
they
sir.
Go for majority a TACAR. But major depression, as you said, more than 8 centimeter do requires exactly the elevation.
Elevation. Yeah, we can be a little bit more aggressive for the articular reconstruction. That's coming era will be tell us that after doing all these things, we can do that as sir suggested, that we can put a scope and see that whatever is not reduced, we can do something for that or something like that.
Whether it will remain, it will last.
Yeah.
It's seen.
Yeah, it is to be seen. Right now, sir, what happens is the posteriorly we cannot see articular surface. That is the limitation. Anteriorly we can see articular surface. So it is always indirect under IITV guidance reduction posteriorly. But anteriorly you can definitely see by submenistral arthrotomy. You can see quite a good amount of articular surface and you can judge the reduction also. But posteriorly not possible to see the articular surface. Till it is fractured, you can see it. Once you elevate it, you can't see it. Because then elevation is up to the extent that you should not be able to see the articular surface. That is the criteria. So that's I follow like that I should not be able to see articular surface. That means it is properly elevated. And my lateral femoral condyle works as a template, so I cannot over elevate it. So I do maximum elevation as far as possible till I touches the lateral femoral condyle. So I may live away with 2-3 millimeter of depression or some subsidence, but that must be working well. That is what I understand. So this is again a.
After that, after elevation.
Yes, I always after elevation fill up with the chronos.
Chronos.
Yeah, I always put the bone substitute, sir. Because they are all flimsy, small osteochondral fragment like surface area. And if we don't put anything, then it can go for secondary collapse. So I always put a chronos and then put a plate.
For that time, there is no metal comes in that piece at all.
Yeah.
Yeah, carry on, please.
Yes, sir, please.
So you do elevation from, if there is lateral condyle depression, you do elevation from the lateral condyle only by opening like book or you do it from opposite side by creating a window?
I usually do submeniscal arthrotomy every time. I see the articular surface always. Even if I do punching from opposite side, but I see from the submeniscal arthrotomy that I am elevating the same fragment. I will not depend on IITV. Better to see the articular surface if you have access available and then do reduction. Intra-articular fractures need perfect reduction is mandatory, and fixation also should be stable and solid so you can mobilize it.
Harjot, if you see submeniscal exposure once or twice, you will never do it under image intensifier blindly.
Yes, sir. Agree.
Jignesh bhai, can I add something?
Please,
In
sir.
those situations where we are going to put a posteromedial plate and elevating a substantial part of lateral condyle by opening the book, submeniscal arthrotomy, and opening the book which you are talking about.
Yeah.
Many times what I have done is that I put a distractor or traction.
That is very nice.
Listen, I judged my posteromedial reduction, but don't put the plate. I hold it with K-wires only, probably, or a clamp.
Right.
And then open the lateral side simultaneously, submeniscal arthrotomy. So if I have not rigidly fixed my posteromedial side, once you fix posteromedial, the vision is very limited for seeing inside the joint. But if you have not completed the fixation, then you can give a varus, open it a bit more, and see it far better. So elevate most of the depressed lateral condyle, then go back and fix the posteromedial.
Yeah. See, what happens is, sir, to do this, you have to do posteromedial in a supine position.
In supine position, yeah.
That is the limitation.
In cases where I'm doing it figure out.
Yeah. Sir, one more thing. We use distractor very infrequently or underused, I say. It is the implant, it is the instrument which should be used a little bit more liberally in a lateral condyle commuter fracture. You put anterior pins and put a distractor on medial side and then distract it, you will have beautiful exposure of the joint. Excellent. You can see a lot of things and you can elevate it very nicely.
My OT boy say that ये सर का गणेश जी है, सबसे पहले इसको शुरू करेंगे.
वो सबसे बढ़िया असिस्टेंट है वो. बीच में भी नहीं आता है, परेशान भी नहीं करता है. Yes, sir.
Lateral condyle, you choose to elevate it from the same side, or you want to go on the opposite side to elevate?
Sir, I see, when I open the door, I elevate from the same side. Unless it is a zero column fracture. I do submeniscal arthrotomy, but elevate from opposite side.
But I feel elevating from the same side, you know whether you are going anteriorly or posteriorly.
Yes, sir.
The depression, you can see it in the CT scan. Where is the depression?
Yes, sir.
You go from the opposite side, it is still a hit and a miss.
Yes, it is always a hit and miss. Always. You can't be sure.
Can't be sure.
Yeah.
Okay, proceed.
Localized depression can be elevated from the opposite side, but broad and it is a comminuted patient, it is always better to do from the same side. That's what I perceive.
Yeah.
Jignesh bhai, barabar hai kya?
Sir, everybody has their own ideas of doing it, but when we are doing from the same side, exposing from the same side, it's better to do under vision only. But if you are doing something blind and not opening the thing properly, not opening the door, then you can try from opposite side, but if you are not happy, then open from the same side. It's like a, as sir said, it is a opposite side is a trial, gamble. We are not sure that we are hitting exactly in the center of the fragment. Elevating from same side will be surety.
If you have done the meniscus opening,
then
you are elevating it from the same side, you know it's coming up. So you are not hitting at the depressed fragment. And it is much more easier to see the depressed fragment from the same side than you try to go blindly on the opposite side. That's how I find.
Yes, sir.
Can you please proceed?
Please, sir. So, sorry. This is the case. Again, this is medial condyle. This is again large total medial condyle. There is no coronal plane fracture. And there is a post-total depression. See, you can see the articular surface depressed. And you large apex on the medial side. So this 3DCT very much communicated. Lateral condyle is sloped and depressed. This complete medial condyle. This is ACL level done. This part of the PCL is with the medial condyle. Everything is there. Okay. So you can see medial femur with the medial condyle. You can see lateral condyle is compressing the posterior condyle part like that. It always goes. This is again varus flexion force. So again, I did the same thing. Posterior medial approach. Put distal screws. Corrected the varus with the joystick. Then fix up with the intercondyle screw. I kept the wire. I put up the proximal screws. Then I put the intercondyle screw. Usually I should not do like that. This is old case. Usually now I do first this screw and then this proximal screws. That is my protocol. Here let's see there is a widening of the condyle. There is screw from lateral to medial, and then I put another plate for a posterior condyle. This lateral plate is not showing very nice. This is the difference of the posterior condyle. This my cursor. I can see posterior cartilage elevation. Elevated and put this 1/3 plate by the side of the medial plate. This is medial plate. This is lateral plate, which is on the posterior condyle. Here, I elevated the condyle, filled up with the chronos, and then put a plate and they screw.
Yes, Jignesh.
Yes,
Jignesh
sir.
bhai,
Yes, sir.
You go back one slide.
go back one. Yeah.
With so much of the overlapping of the lateral condyle,
Yes, sir.
I think it is you have missed out something in the center.
So this is what I was talking
I have
about.
not elevated.
Yeah.
I have not yet elevated this portion. Sir, you will see posterior axis, it will be perfect.
No,
I have elevated everything. I have elevated everything and done it.
No, Jignesh bhai, that is very annoying. This is what upsets me. I work for 4 hours and then see this. How do you correct this?
I have corrected it. I am showing you. I have corrected it, sir. This is the thing which I will show you posterior. This will be corrected.
Please show the final X-ray, Jignesh.
उसमें नहीं दिख रहा था वो.
Corrected.
Okay. Good.
Sir, I have done this clearance. ये clear करना है जरूरी है इधर.
No, but why that X-ray was looking like that?
Because I have not done anything there. तब मैं उधर कुछ नहीं किया था. देखो सर. मैंने इधर कुछ नहीं किया अभी तक. अभी I am only on medial condyle. Here medial condyle only. I have not done any correction here.
Okay.
मैंने उसको साफ नहीं किया अभी तक.
After that, you cleared out those small pieces which you were talking
I
about.
removed everything. I have put it then see. This is posterior X-ray. Correct हो गया ना सर? बराबर हुआ.
हो गया बराबर. Perfect.
This is
And
very
this is the function also.
Thank you.
इसका सर 5 साल का follow-up है. 7 years follow-up now. Perfect है.
Now, Jignesh, this is very often seen.
Yes, sir.
Operating upon an old fracture. Because all the time in the old fracture, that in phase unless you cleared it out completely.
Yes, sir.
Condyle will always be overflowing it on the lateral side.
Sir, this is what happens always. We don't clear the intercondyle commission. That's why it remains wide only.
Exactly.
We have to correct it, clear it here very nicely.
If you go down, you will realize it.
Yes.
Articular surface, B2 articular surface, between that, there is the fibrocartilage. And that is all what is the gap which is separated out.
Yes,
so
sir. Yes, sir.
Osteotomy, all that area you will have to excise it, complete.
Yes, sir.
Very good. Please carry on.
Yeah. Another one, this is posterior bicondylar tibia. Now, this pattern is classic photogenic injury. This coronal posterior medial condyle. This is depressed posterior condyle. And this is displaced posterior medial condyle. Okay. And this is 3DCT. So, A is ACL. P is PCL. Is a part of the posterior medial condyle. This is depressed posterior condyle. Unless you reduce this posterior medial condyle and plate it, you cannot reduce and elevate posterior condyle. Not possible. Because this will go posteriorly and it will cover the posterior condyle. So we cannot address this unless we reduce it perfect 100%. See this coronal plane fracture. It is completely back behind this condyle. The moment I reduce it, I will be able to see this fragment completely in front of my eyes. So, and this PCL is a part of this posterior condyle. Okay. So this is the injury assessment. Now what is the plan? So extended posterior medial approach, prone position. First, reduce posterior medial condyle like this. put a plate on posterior condyle. First screw at the apex, then rest of the screws, right? Over. This is done. Now go posterolaterally here. Elevate the things and put a filler, then posterior plate and screws. This is the pattern of the fracture. And this is ACL. Your minor fragment was there, we left it. Or I had done screw, let us see. So this is what we, this is the pattern of the fracture. And it needs fixation and planning like this. So this is exposure. Posterior middle plate, posterior plate. Sir, सामने दिखता है गड़े गए सर?
Yes sir, दिखता है बिल्कुल.
नहीं सभी दिखता है. मैंने आज किया तुम्हारे मेथड से.
मेरे मेथड नहीं है सर. This is method for everybody. ऐसा ही है. ये करने का नहीं भूलने का. टीनोटॉमी इधर, टीनोटॉमी. मैंने सिर्फ टेंडन काट दिया, बाकी मसल नहीं दिया. और इधर से सोलियस उड़ा देने का, सोलियस. तो पूरा दिखेगा. And vessel will be between the popliteus and the gastrocnemius, so no problem. ये सभी टीनोटॉमी है इधर.
Jignesh bhai, a word about where do you put your spike, that sharp spike, where do you put it? Will be useful tip for the audience.
Yeah. सर ये स्पाइक आप है ना, आप यहाँ कहीं भी लगा सकते हो, लेकिन ये इधर के जो स्पाइक आएगा ना, that will be on the lateral condyle, between the fibula head and the lateral condyle. नीचे नहीं जाने का, नेक में नहीं जाने का, नेक में anterior artery आता है. So this is post-op X-ray. I did ACL also here, small fragment, so Ferber screw, patient को supine करके कर दिया था. Another one. Now we will go to lateral condyle commuter fractures. This is the plating was done for a commuter lateral condyle, acceptable or needs improvement. This was the pre-op X-ray. This is the post-op X-ray. There is something missing here. That is the posterior condyle. ये injury pattern था सर इसका. Posterior condyle, anterolateral condyle, and the fibula head. This is fracture. Like this. So wrap plate will not hold this fragment. You have to do something anteroposterior. But anteroposterior screw will not reduce this apex of this buttress fragment. So these needs double fixation, posterolateral as well as anterolateral. So this fragment cannot be fixed by a wrap plate. So what you need is first buttress this posterior fragment, reduce anterior fragment on that, and that should be the approach. So female 54 years, same injury. Posterolaterally two split fractures, anterolaterally this is lateral condyle, this fragment, and this anterolateral fragment is there. This is anterolateral fragment, my cursor. This is posterior fragment. So we did with the Frost approach, direct lateral approach. First posterior plate buttressing, and you can see it has perfectly reduced the posterior condyle. And that's the immediate post-op X-ray. And that's the follow-up X-ray. So this type of fracture of lateral condyle, which has got both the components, needs direct lateral approach, and it is called as a Frost approach, which allows to go with keeping the fibula head, common coronal nerve, and lateral caudal ligament in the center, anterior and posterior to the fibula head, to fix up the lateral condyle circumferentially. This so here I did not put any proximal screws, and I just fixed up. I just buttressed it, and it stayed. Actually, I should have put the old case. If I do today, I will fix it 1 or 2 screws.
Vignesh bhai,
yes,
about
sir.
that plate, I find putting a 4-hole plate very difficult. So how did you manage that? Go back one slide. There are 4 holes in the proximal end.
Yes, sir.
So how do you find out so much of space there? The space is
Sir,
very
you just slide the plate underneath. That's all. It goes like that. I have done PCL fixation also from this posterior approach. Little bit difficult, but I could manage to do it. So with experience, you can have a little bit more daring. Daring आ जाता है. तो हो जाता है सर ऐसा. So recently I did one PCL fixation through posterior approach because it was with the PCL with posterior condyle, rare injury. So I had to do because I didn't want to take another posterior approach for PCL fixation. So I did it from the same approach. थोड़ा risky था लेकिन कर दिया सर. तो थोड़ा एक्सपीरियंस के साथ थोड़ा हो जाता है कि तुम 4 होल का 5 होल भी लगा सकता है, धीरे से घुस जाता है अंदर. Otherwise 3 holes are enough and you most of the time you need only 3 holes only and fix it with the screw. Okay, sir. Another one. This is case for just an assessment, how we assess it. See, this injury was very bad. Okay. This is PCL fragment. This is medial condyle fracture. This is anteromedial condyle fracture. This is lateral condyle fracture. So these are the elements of injury. So posterior PCL was like this. Okay. Now, how many approach and how to do it? So patient had a very bad skin, so we waited for a few days. After that, there was ecchymosis. We put up a fixator, then removed the fixator and then operated. This is the anteromedial condyle. This is medial condyle. This is PCL. So medial condyle has a medial apex. PCL was separate fragment. This is lateral condyle and the anteromedial condyle, like that. So after a few days of waiting, I could manage by 2 and 3 of third approach for the PCL small incision. And I did this medial approach, anteromedial and medial plate, then raft plate, and then PCL. I could get perfect reduction and everything. So first I did medial approach. I went medial border, medial plate, then anteromedial plate, then the raft plate, and then last PCL by small incision. So I could manage to do that. So always divide the component of all the injury, assess them, then define your sequence. Always do medial first. If it is anteromedial, then do anteromedial first. Then do posterior, then do lateral, and then PCL. It is to be separate. If it is the same approach, then PCL also with the medial condyle. First medial condyle, then PCL. This is the sequence usually we follow, and it usually falls everything in position in a perfect way.
Vignesh bhai.
Yes, sir.
When you are in need of doing anteromedial and the posteromedial both,
yes,
and
sir.
you rightly said that anteromedial has to be reduced to the distal tibial shaft.
Yes, sir.
So,
perfect.
Yeah. So, don't you think a posteromedial approach as slightly longish incision, you can raise the flap and do both through the same undervision?
Supine position, okay.
You are lucky that you just pulled it and it fell back, so you did a percutaneous.
Sir, here I opened up. See, I did
but
medial
you'll be very hesitant to put anteromedial and a posteromedial incision very close to each other.
Sir, here I did only medial approach. See, this is
Okay.
the incision.
Yeah, this is what I was talking about. Okay,
Yeah.
only. Yeah.
I do with medial approach and go anteroposterior simultaneously. I have done a number of cases like that, but here right now the sequence is going like that.
Yeah.
Okay. Now another one. Again, see, this is the medial condyle fracture. Complete medial condyle fracture with medial apex. Then is the lateral condyle, which is anterolateral and posterior part, and that is the central part of the lateral condyle. So lateral condyle has 3 parts: central, anterolateral, and posterolateral. Here, see, this posterior part is here, posterolateral. This is the condyle fracture. This is the medial condyle with the medial apex. This is the medial condyle with medial apex. See, exit medial apex. It needs plate on the medial border. Again, you need 2 approaches. One for medial condyle, one for lateral condyle, which can address central part, anterolateral part, and posterior part. So I did first in supine position medial condyle plating, and then lateral position and did Frost approach to reduce all 3. Actually, it looks bad, but see, 3 large fragments. This is 4th fragment. So this is only 4 fragments to be fixed. Easy. This is the understanding. This is first medial plate. Under is the pass, sir. I did not cut the pass.
Yeah.
And then this is common perineal node dissected. This is posterior condyle. This piece is here, this piece. And This is posterolateral plate. This is the nerve which is relaxing. Then this is anterolateral condyle. This is central condyle. These two. I elevated them. This is the meniscus. And this is meniscus. I reduce this all three fragments together. This round is lateral condyle. This round. This yellow arrow is this yellow arrow. These two central portion. These two pieces. Elevated, provisionally fix with K wires and don't put a plate. So anterolateral plate, posterolateral plate, and medial plate, right? And this is post-op X-ray. Everything nicely reduced. You can compare with the pre-op X-ray. This is the pre-op X-ray.
Badhiya.
This is everything perfectly done.
Jignesh.
Yes, sir.
This looks fabulous, but if you split hairs, then there is widening of the tibia, which I find very annoying in the post-op
A little bit.
Can we find out the cause? You can
Sir,
see
here,
it may be the normal thing.
Here it looks perfect.
Yeah, it looks perfect.
See, you can what I have not done probably here. You can do before fixing these proximal screws, you can apply one clamp here and compress.
Okay.
And it can reduce because there is no commission here. It was only all clear fragments. See, you can see large pieces only. There was no commission to clear off. Here it did not require any clearance. So whatever the things have fallen back, I have accepted it and fixed up.
Yeah.
So I just reduce line to line. It may be widened by 2 millimeter only, nothing more, 2-3 millimeter.
I can say, Jignesh.
Yes, sir.
Here in the lateral view, in the AP view here, there is a small thing which is probably if you are putting
this one. Yeah.
you are putting the screw outside the plate and compressed it.
Compress it. It can be possible, sir.
And you will have been able to eliminate the gap. Small.
Yes, sir. Yeah. Agree, sir. We can do that elimination of the gap and compression.
Yeah.
So we can improve a little bit in this, again, all this scenario also.
Beautifully done. Thank you.
Thank you, sir.
Wow.
So replacement surgeon gives knee for 20 years to old patient. So we have to give knee for 35 years to young patient. So reconstruct it well with good reduction and fixation. That will help in a future replacement also. And these are the approaches. Medial condyle, medial and anteromedial. This is posteromedial and external posteromedial for posterior surface. Lateral side, anterolateral, cross, suprafibular, and posteriorly posterolateral. So this is a good picture. These are the approaches usually we come across around the tibia. So if we assess the fracture very well, we can select the approach accordingly. And we have to plan out. So I cannot teach anybody anything. I can just make them think. Thank you very much, sir.
And you can teach many things, Jignesh.
Nothing like, sir. We are just discussing the things,
quite a lot.
exchange the ideas.
Superb, Jignesh. As I say, every time I hear you, I learn. Lovely.
Thank you very much, sir. So kind of you, sir.
Jignesh bhai, do you
मेरे mentor तो
remove your implants?
बराबर मुझे लाया इधर. मुझे
Jignesh
nobody was
bhai,
showing me.
do you remove your implants?
Sir, when patient demands, I remove. Otherwise, I don't tell them to remove.
No, you discourage them, or if he comes back, निकाल दो तो निकाल देता है.
मैं निकाल देता हूँ, सर. टाइम हो गया तो निकाल देता हूँ. सर, कोई प्रॉब्लम नहीं होता है. I go to the same approach which I have operated, so no problem. Easy to remove, I tell you, frankly speaking.
Yeah.
Not that difficult as we believe.
Jignesh bhai, what is your observation of a very delayed infection, a mild infection, which necessitated removal of the plates?
Sir, in that case, we should remove the plate. Otherwise, it will not stop. It will go for osteomyelitis. It's better to remove the implant and clear everything.
Okay, Jignesh, I think thank you very much for today.
Yeah, thank you very much, sir.
So I have a few cases to discuss. Can I share my slides?
अगले हफ्ते
अगले 10 बज गया.
Okay, sir. For next time then.
Sir, next time chance मिलेगा तो approach दिखाएगा.
Then we start with your slides, though.
Jignesh bhai, most of your approach lectures, talks, they are on the OrthoTV available.
Ortho, it is there. So you
Yeah,
can
very
everybody
beautiful
can go
videos
through
are
it.
there.
Yeah, it is there. Yeah, please.
वो कैसा है
असीम,
असीम भाई,
हाँ.
वो कैसा है, जिस तरह से वो समझा देता है ना, हमारे जैसे समझता है।
टीवी पे नहीं समझता वैसा.
Okay, friends, if you have questions to Jignesh, ask him, because it is already 10:10 now. So we meet.
Yeah.
Thank you very much, Jignesh.
Thank
you
you.
very much, sir.
Thanks a lot.
Thanks a lot. Thanks a lot.
It was good time spent.
Thank you very much, sir. Thanks a lot.
Thank you, sir. Thank you.
हेलो जगदीश सर.
हाँ सर, प्लीज.
हाँ, अगर पोस्टरोलैटरल एंड पोस्टरोमीडियल फ्रैक्चर एंड एंट्रोलैटरल एंट्रोमीडियल फ्रैक्चर, तो आप पोजीशन कैसे चेंज करते हो?
सर मैं क्या करता हूँ, आई यूज बिग टॉवेल्स टू ड्रेप, राइट?
ओके.
मैं आई यूज बिग टॉवेल्स, बड़े बड़े टॉवेल यूज करता हूँ ड्रेपिंग के लिए, छोटे टॉवेल यूज नहीं करता हूँ. तो क्या है, मुझे कम टॉवेल यूज करना पड़ता है और मेरा पीछे पूरा कवर हो जाता है, राइट? मैं टॉर्निके बांध देता हूँ पहले, बराबर. उसको एसवर्क बैंडेज रखता हूँ, तो मुझे प्रोन में भी मैं एलिवेट करके उसको एक्सिग्यूट कर सकता हूँ. या तो क्या करने का कि सुपाइन में उसको पहले टॉर्निके चढ़ा दो, बाद में प्रोन कर दो, तो आपका झंझट नहीं रहेगा, राइट? फिर है ना सर, पेशेंट को प्रोन में ऑपरेट कर दिया, अभी सुपाइन करना है, तो आई रोटेट द पेशेंट अंडरनीथ द ड्रेप्स, सो आई डोंट डू होल ड्रेपिंग एंड पेंटिंग अगेन.
ओके.
मैं उसी को अंदर ड्रेप्स के अंदर घुमा देता हूँ, बाद में वापस बड़े बड़े 3 टॉवल डाल देता हूँ, पेशेंट कवर कर देता हूँ, एंड आई ऑपरेट लेटरल साइड. आई रिलीज द टॉर्निके बिफोर क्लोजर ऑफ एवरी पोस्टरोमीडियल एक्सपोजर.
Okay.
Always release the tourniquet, confirm that there is no bleeding, then close down the posteromedial wound. तो tourniquet खोल दिया आपने, क्लोजर कर दिया, तो 15-20 मिनट हो गया, तो you got now time. So supine कर दिया, बाद में tourniquet वापस चढ़ा दो. Now you get again 90 minutes to operate.
ठीक है, समझ गया. Okay, thank you sir.
Yeah, please.
Okay, thank you.
Welcome. Yeah. Anybody want to ask?
नहीं, Jignesh bhai, everybody has left.
Okay.
So next Thursday again, we'll inform you if we are meeting.
Okay. Please sir.
सर एक बार अप्रोच का एक लेक्चर अच्छा होना चाहिए टीवी के लिए.
We'll arrange that.
कर देंगे सर, ऐसे उधर तो है ही, यूट्यूब पे तो है ही, लेकिन इधर वी कैन डिस्कस डायरेक्टली स्टेप बाय स्टेप, करना है तो.
Okay.
Anytime.
Thank you so much. Good night.
Okay, thank you sir.
Bye.
Thank you Jingis sir. Okay.
बोलिए सर. कर सकते हैं. सर अगर पोस्टीरियर बॉर्डर टूटा हुआ है तो कर सकते हैं। अगर तो आपके सामने मैं फोटो देखा नहीं है, एक्सरे आपने भेजा है। मैं एक चालू रखे, मैं चालू में देखता हूँ, बताता हूँ। मैं उसको देख लेता हूँ, मैं उसको देख के फिर आपके अपन बात करते हैं वापस, है ना सर? प्लीज वी टॉक, या प्लीज, थैंक यू। नहीं नहीं सर, ऐसा कुछ नहीं है। Nothing like that, sir. It's all extended sharing of the knowledge which we gather. Rather, sir, आपके questions. सर आपका है ना, आपके क्वेश्चन ने मुझे वाइजर बनाते हैं। मैं ज्यादा थिंकिंग करने लगता हूँ कि ये असीम पूछेगा तो क्या बोलेगा ऐसा। सही बात है। सही बात है। या डेफिनेटली या मिलते हैं सर, बाय, थैंक यू। फरमाओ हुक्म। हाँ कर दे शनिवार, साथे कर दे शनिवार सवारे तो 9 વાગે રાખી દઈશું આપણે। 9 થી 10 પતી જાય કલાકમાં, કેટલી વાર આવે? સાહેબ આવે ને આપણે કહું અહીંયા સભે ને કે એક ગંદે આવ્યું છે, બસ બીજી કઈ કરવા નહીં. શનિવારે એડજસ્ટ કરી દઈશું એટલે કાલે. હા સાહેબ. ચોક્કસ. સુંદર ને? હા હા રાખી દો સોમવાર સારું. સારું સારું. Everybody